Welcome to Medical Logistics 101 Trauma Overview. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Hospital trauma classification. Level 1 is tertiary care facilities central to our trauma system. Provides care for every aspect of injury, has 24-hour coverage of all needed specialties, including specialty services such as neurosurgery and interventional radiology. Level 2 has 24-hour coverage of general surgery and orthopedics. Some specialty services may be limited coverage. Level 3 generally has coverage of general surgery, but other services may have intermittent coverage. Level 4, basic emergency services such as advanced trauma life support to stabilize patients for transfer to a higher level of care may provide surgical services if available. Level 5, very limited service, focuses on advanced trauma life support and ideally rapid transfer to a higher level of care. The pre-huddle. This is basically EMS has notified the staff that a trauma patient is en route. If the patient arrives by EMS, allows for staff to ready necessary personnel and equipment prior to arrival. This will include gathering airway equipment, prepare tourniquets, pressure dressings, set up IV supplies. The goal is when EMS arrives, team is ready, not scrambling. The size of that pre-huddle would depend obviously on the size of the facility. Some larger hospitals are going to have a lot more resources they can call upon for that. Primary survey. First step, stop the bleeding. Clinicians trained to recognize arterial bleeding. Emphasize more and more, and quite honestly, if they're coming by EMS will generally have applied tourniquets prior to arrival, but clinicians are trained to recognize arterial bleeding and apply tourniquets where appropriate. If there are extremity wounds with arterial bleeding not responsive to direct pressure, clinicians will place a tourniquet 2 to 3 centimeters above the wound, but not at a joint. Identification of other external sources of bleeding, such as scalp wounds. And always document the time when tourniquets are placed. Airway. Can the patient speak? Is there a presence of stridor, high-pitched, noisy breathing? Oral secretions or blood present that require suctioning? Patient may need assistance with ventilations. We evaluate the need for a definitive airway, such as endotracheal tubes. If severe facial trauma is present, this might require the clinician to place a surgical airway, such as cricothyrotomy. Rapidly reassess after any airway intervention. Breathing. Chest rise, is it symmetric? Is it moving equally bilaterally? Breath sounds, are they clear bilaterally? If they're not, I would be suspicious for a possible pneumothorax. Workup breathing. Obvious chest trauma. Oxygen if needed. If a pneumothorax is present, this will need to be addressed quickly. Circulation. Major bleeding. If external, should be addressed at the time of arrival. Pulse quality. Skin color. Capillary refill. Blood pressure. Early and adequate IV access. If the patient is unstable and unable to obtain IV access, certainly consider intraosseous access. IV fluids if indicated, ideally blood products as rapidly as possible if mass hemorrhage is present in a 1:1:1 ratio if available. The 1:1:1 ratio is fresh frozen plasma, packed red blood cells, and platelets. Some small facilities are not going to have all three of those. They may only have packed red blood cells. But again, if it's a small facility and they know that they have to transfer that patient just because of the nature of their injuries, they may start blood, but blood may not even be completed by the time that the patient is transferred. Disability neurostatus. Are they awake? Are they responding appropriately? Are they moving all limbs? Are their pupils equal? The Glasgow Coma Scale. That is, a 15 is normal on the Glasgow Coma Scale. If they're 8 or below, they need to be intubated. Exposure environment. Patient must be exposed head to toe to evaluate for occult injuries. If you haven't looked, then you don't know the extent of their injuries. Patients should never be transferred with their clothing still intact. I'm talking about transfer from the receiving hospital. Guard against hypothermia. You've exposed that, and hypothermia happens fairly quick. You can't treat what you don't see. Log roll the patient while protecting the spine. Generally, labs are drawn when the IV is started. I will often include a chest x-ray, pelvis x-ray, and a fast scan in the primary surveys. These can be done at the bedside. When I say chest x-ray, I mean a portable chest x-ray at the bedside. Same thing for the pelvis x-ray. And the fast scan, which stands for Focused Abdominal Sonographic Test, is an ultrasound that's done right there at the bedside. Event mechanism. What is the story of how the injury occurred? high-speed crash? Was it an assault? Was it an electrical burn, which could be deceptive? They may not have obvious injuries externally with the electrical burn. Decision point, ideally, you should know if you're transferring within 15 minutes of arrival if you worked in one of these small rural hospitals. Early activation of trauma system, ideally with rapid acceptance and transfer assets such as air transport on the way. We do not delay emergent transfers for other testing such as CT scans. If the FAST scan, that bedside ultrasound scan, has identified internal bleeding in the abdomen, CT wastes precious time. Now, the FAST scan doesn't tell me where it's coming from, but it tells me there's active bleeding going on in the abdomen, and if I don't have surgical support, I can't address that at my small rural hospital. So these patients need to be immediately transferred, and you certainly don't need to waste time obtaining CT scans. Secondary survey. Only done after life-threatening injuries are addressed in the primary survey and no immediate need for transfer is identified. If there is an immediate need for transfer is identified, such as internal bleeding in the abdomen, that patient, or potentially severe head or neck injuries, that patient would need to be immediately transferred and there would be no secondary survey. Additional history, ample. Allergies, medications, past medical history, last meal, events, environment related to the injury. CT scans as appropriate. Again, this is someone that's stable and is not requiring immediate transfer. Additional labs as needed. Never delay transfer for the secondary survey. Pitfalls. Always call EMS. Do not attempt to transfer the patient by a private vehicle. Advantage in the rural areas is that EMS recognizes injuries that require a tertiary care hospital. They can activate the trauma system and air transfer early, saving precious time. That might be helicopter transfer from the scene, and they totally bypass whatever local hospital they have and directly to the tertiary care center, but that can be affected by things such as weather. Is the helicopter available? Obviously a very limited resource. Early and rapid treatment of any external bleeding. Tourniquets are a lifesaver when indicated. I absolutely recommend as many people as possible to obtain the training, the Stop the Bleed training in their application. We do not delay transfer for the testing, does not change the need for transfer, such as CT scans. One little thing I would say on that that can be a potential pitfall that I've seen is that you have someone that's being transferred and maybe they're going to a facility that has general surgery coverage that could deal with potentially internal bleeding in the abdomen, but maybe they don't have neurosurgical coverage. So, and without the CT scan, I may not know the extent of their neurosurgical injuries. So that could be a problem and sometimes can result in someone being initially transferred to a facility that certainly could deal with one degree of injuries but could not deal with any sort of neurosurgical injury. Closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.